Hey you guys, it's Nurse Desi. I'm back with another video. If you guys are new to my channel, let me introduce myself. My name is Destiny. I'm a 22-year-old registered nurse and I currently work on a medical surgical ICU. I am on week 11 of orientation and I have a 16-week orientation, and I'm also in a 1-year-long residency program. So if you guys are interested in nurse content, if y'all are in nursing school, then y'all can go back and look at my nursing school vlogs. If y'all are new grad nurses or interested in working in ICU, you guys are gonna love my channel. Please like, comment, and subscribe, and let's get into this video. Okay, you guys, so today is Monday, May 13th, and I'm starting a new vlog. So last week it was Nurses Week, y'all. I hope you guys had a great Nurses Week, and it was also Mother's Day, so happy Mother's Day to all my mommies, all women that are soon-to-be moms, and then anyone that is a mother figure to anyone in your life. Happy Mother's Day to you as well. So this week is a very exciting week, y'all, because it is week 11 of my orientation, and this is my last week on day shift. So y'all know I'm a night shift crew. I worked 2 years as a patient care tech on nights, and nights just have my heart, y'all. I love night shift. I love the night shift crew, and I've been waiting to go back to night shift, y'all. So this is my very, very last week on day shift. So I am, today, it is Monday. I don't have work today, but I do have to study because we have a medication exam on Wednesday, and it's really important. It's like 50 questions, and it's on all of the important medications that we give in the ICU. We have to get over 80%, so I have to study for that today because I've had an exciting weekend. I got my hair braided. I got some Fulani braids. I spent the whole weekend with my mom and my sister just enjoying Mother's Day. So today I really got to study. So I'm actually going to go to Barnes & Noble so I can get some good studying done. And then tomorrow I have a 12-hour shift. So that's why I really need to study today because I have a busy shift tomorrow. And on Wednesday is the medication exam. And then it's also a rapid response day. And it's a class that we have to take at the end of the rapid response. We have to learn how to use this thing called a hemisphere, and it's pretty much what we use to see the patients, like hemodynamic monitoring, so like stroke volume, all the important things that we look at in ICU. It's a monitor to help us read whatever the patient is going through, and we need to learn how to set it up. So we got to take a class on setting it up. And then on Thursday I have off. Friday is my very last shift on day shift, and then I have 1 day off, and then on Sunday I go to night. So very excited, y'all. I wanted to vlog this because I want to get my preceptor a gift for taking this 11 weeks to train me. She is the best, y'all. I had the best preceptor ever, so I want to get her a gift and just do some nice things for her. So I'm going to bring you guys along this week. Hope you guys enjoy this vlog, and I'll talk to y'all later. Okay, you guys, so I'm on the way to Barnes & Noble, but I forgot to tell y'all what I did last week. So I really should have vlogged last week, but it was such a busy week. I had a lot going on. I was doing a lot for my mom, trying to do all this stuff for Nurses Week, so I really did not have enough time to pick up the camera, but I did film the video on how to become an ICU nurse. So if y'all have not watched that video, go watch that video, y'all. But last week, so my educator sent out an email, and she was saying that if you want to go to an optional practice ACLS class, it is being offered by our rapid response nurses in our hospital. So for y'all don't know, in the ICU we do have to be certified in ACLS. It's pretty much like BLS, but it is advanced life support, and it is, if a patient is coding, it's everything that we need to do as ICU nurses. So how to operate the code card, how to, like give quality compressions, how to bag the patient, how to manage the airway, how to be the recording nurse, how often like we can give epi, how, like, what is the algorithm based off of what rhythm the patient is in, and also how to operate the cardioverter and the defibrillator. So it was a lot, y'all, and I'm like, I don't even know how that class was optional, because I feel like that should have been a mandatory class. And when you're at school or when you're at a job and they offer like optional educational sessions, I know that people don't be wanting to go all the time, but you need to take advantage of sessions like that. I don't care if it's optional or not, you need to go. So that was probably the best class I think I've ever signed up for, y'all. My rapid response nurses are so freaking good. Like, they took us down every single algorithm that a patient can go through. First, they went over cardiac like rhythms, and I've already taken the cardiac exam and I passed. But you need to be constantly being refreshed on these cardiac rhythms, heart blocks, all the lethal rhythms, VFib, VTAC, all that, PEA. You need to know what those rhythms look like, and you need to know how to assess for them. So she went over that again, and then the other nurse went over airway, so how to properly bag the patient, the checklist for intubation, and then also like some other things that we need to know, whether patients that are having like a respiratory arrest, things like that. And then after, they went over all the algorithms. So y'all, like, I know, like, it's like, of course, you know, if a patient is coding, like, go check a pulse. If they don't have a pulse, you need to start CPR. Like, you know those basics. But there's a lot about ACLS that it goes into a deep dive of if a patient is having like a bradyarrhythmia. So their heart rate is in the 30s and they are asymptomatic. So if they're stable, it's a whole algorithm that you need to go through. So if a patient is stable, of course you still need to monitor them because that heart rate may not be enough to be providing them perfusion. So you need to be monitoring them. You need to check their blood pressure and make sure that they're not having symptoms and figure out why they are in this heart rhythm. Are they having a heart block? Do an EKG. Are they having a STEMI? Like, it's a lot of reasons why patients could be having a bradyarrhythmia. So you need to be doing investigations. But if a patient is unstable, so if they are hypotensive, short of breath, unconscious, altered mental status, diaphoretic, clammy, all the symptoms they taught you about in nursing school with the patient that is in some type of shock, that means they are unstable and you have to move fast. So of course, for bradyarrhythmia, the first thing that we would give if they're unstable would be atropine. And then it's a algorithm that goes on from there. So if atropine doesn't work, then put the pads on them and start pacing them. So we would have to know how to work the Zoll monitors in order to pace the patient properly. If pacing doesn't work, then start giving either epi or dobutamine. If dobutamine or epi doesn't work, then they're gonna have to go to the cath lab and get transvenous pacing. So there's a lot that is going to have to happen, and they're probably going to end up having a pacemaker permanently if they cannot fix the rhythm. And then there's a whole other algorithm for if a patient is having a tachyarrhythmia. So SVT, if they're in AFib, RVR, if they are in a flutter, if they're in VTAC but they have a pulse. It's a lot of things that we have to do. So we learn how to cardiovert a patient that is an SVT. We also learn if a patient is having a cardiac arrest but they're in a shockable rhythm, so like VFib or VTAC but pulseless. We learn how to defibrillate them, how to, like, what algorithm of medications to give, amiodarone. It's so much that goes into it, y'all. That class was so freaking needed. Like, I feel so confident now as ICU nurse, knowing that if my patient goes into some type of unstable arrhythmia, I know what to do. And what I did not know that we were going to have to do is a mock code after the fact. So my hospital does have a sim lab, just like if we were in simulation. And fun fact, so I never knew this, but my hospital used to also be a nursing school. So they have a whole sim lab that a nursing school would have. So mannequins, code car, everything how you would do in nursing school. So it literally felt so like nostalgic going into a sim lab, because I'm like, I literally was just in nursing school doing all this, and I'm doing it as a nurse. Like, learning never stops. You're always going to have to continue to learn. But the rapid response nurses, they were so nice. So they were working the mannequin behind the glass, and then it was another one that was in there, and they pretty much like immediately put us on the spot. So it was 2 scenarios. It was only 4 of us, so I volunteered to go first, and they gave us a scenario, and they're like, okay, if a patient, a 52-year-old male, comes in, chest pain, shortness of breath, and then boom, like the simulation just started. And I was like, okay, so what do I do? Like, what else? And she was like, you have to ask me questions in order for me to continue to give you more information. So first thing I did, assess the patient's like their level of consciousness. Hey, do you know your name, your date of birth, making sure that they're fully awake. And then I was like, okay, can I see the vital signs? So then they showed me a monitor. Patient's heart rate was like 180s. They were in SVT, and I was asking the patient, how are you feeling? And the patient was like, okay, I'm having palpitations, but I'm not feeling like bad. Like, I'm just feeling like my heart is beating very fast. So that is a primary example of a stable SVT. So if a patient is in a stable SVT, there's some things that you can do before you immediately jump to like cardioverting. So one of the most non-invasive things is asking them if they can do a vagal maneuver. So that is like asking them to bear down, acting like they're having a bowel movement, asking them to hold their breath for 10 seconds, things like that, because they can actually naturally convert the patient back to normal sinus rhythm. So I asked the patient to do that. The heart rate was still in the 180. So second thing that we can do is adenosine. Y'all know adenosine is scary. That is one of the scariest drugs. I think I never pushed adenosine, and I don't want to ever do it. But adenosine can temporarily, so it slows down the AV node conduction, and it can temporarily put your heart in asystole in order to convert you back to normal sinus rhythm. So we can do that for a patient to convert them back. And so I pretty much was verbalizing everything that I would do for this patient, going down the algorithm. So I was like, okay, I would give this patient adenosine 6 milligrams. If that doesn't work, then you can give 12 milligrams and continue to go up until 3 times. And if that does not work, then it's also some other things that you can give, beta blockers, calcium channel blockers. Typically it doesn't work, but it's something that you can try. But so while I was in the simulation, the patient ended up turning unstable. So now the patient's blood pressure was dropping, and they are symptomatic. So they're having shortness of breath. They are not able to get enough perfusion. If the heart is beating too fast, then that means that the body is not getting enough perfusion to perfuse your vital organs. So that is an unstable SVT. In that case, we would have to externally cardiovert the patient. So I was like, okay, I'm going to put the pads on the patient. I'm going to sync them up, because when you're cardioverting, you have to sync up the patient's R waves on the Zol, or if you shock them on the wrong place, like in the T wave, you can send the patient into VFib or VTAC, and the patient can code out on you. So I cardioverted the patient, and it was like so crazy because I was in the situation. I had to critically think so fast, and it just shows how you have to do as a nurse on your unit. Like, you don't have enough time to just be like staring at the monitor, not knowing what's going on. So now I get why they make you do cardiac tests, cardiac rhythm tests, because when the patient is in a lethal rhythm or something's going on, you need to know what to do. So it was like I was all like verbalizing everything that I would do. I was like, okay, I'm going to cardiovert this patient. And then I cardioverted the patient. It did not work. And you can continue to cardiovert, like just going up on the joules, up on the amount of energy that the patient is getting during the cardioversion. But in the middle of the cardioversion, the patient ended up going into VTAC, and they coded. So now I'm like, okay, I would immediately initiate CPR, check for a pulse. If there's no pulse, CPR, start bagging the patient, and then since I recognize the rhythm is VTAC or VFib, I would defibrillate this patient. So now I have to go down the cardiac arrest algorithm. So now it's like everything starts to make sense, like why we do what we do. It's all algorithms, it's all mapped out for us. So it's not like we're reinventing the wheel. We already know exactly what to do, but you have to be able to identify what is happening in order to know what to do. So that was probably the best class I think I've ever taken, and I just wanted to explain this to you guys, how y'all can like know that you have to continue your education as a nurse, and you don't want to be caught in a emergency and you did not know what to do, and everybody's looking at you like you're the nurse, you're supposed to know what to do. So it was just crazy that out of all like the people that could have showed up to the class, only 4 people showed up to this class, y'all. And the rapid response nurse said mostly ICU nurses typically do not come to this class because they feel like we're already in the ICU, the patient's already critical, like we don't need to come to a rapid response class. But no, you need to know what to do, because there's a lot of times when patients are coding and people are just fumbling around, don't know what to do. So that class was so needed. I needed to explain that to you guys. I felt so good. My rapid response nurse was like, you are really good. And she said that I'm gonna be a great ICU nurse, so that really hyped me up. But I'm gonna go ahead and study. I'll come back to y'all as soon as I get there. So I'm at Barnes & Noble, and since I just got here, I want to go ask Barnes & Noble if they have the CCRN book. If they don't, I'm going to go ahead and order it. And I know it's probably a little too early to be studying for my CCRN, but I just love learning more and knowing what is going on. Like, I'm telling y'all, it is the worst feeling to be in a situation and you're not understanding what's happening with your patient, and you want to provide the best care, but you need to know what is going on before you can advocate for your patient, ask for certain things from the doctor. You want to know exactly what steps to take, and it all starts off with understanding the the physiology of what is going on with your patient. So I want to go ahead and get the CCRN book. I'm going to ask Barnes & Noble if they have it, and if not, I'll just order it on Amazon. But I just love learning. Everything starts to make sense when you are at work, and the intervention that you're doing is starting to make sense when you fully understand what's happening. So I'll go ahead and show y'all the medication exam and everything that we're going to be studying, and I'll also show y'all if I get this book today. So talk to y'all later. See, my days are cool without you, but I'm hurting while I'm near you. And though my heart can't take no more, I keep on running back to you. See, my days are cool without you, but I'm hurting while I'm near you. And though my heart can't take no more, I keep on running back to you. Baby, I don't know why you're treating me so bad. You said you love me, no one above me, and I was all you had. And all my heart is beating for you, I can't stop crying. Treat me this way and still I stay. See, my days are cold without you, but I'm hurting while I'm here. And though my heart can't take no more, I keep on running back to you. See, my days are cold without you, but I'm hurting while I'm here. And though my heart can't take no more, I keep on running back to you. Baby, I don't know why you wanna do me wrong. See, when I'm home, I'm all alone, and you are always gone. I can't see how you could bring me to so many tears after all these years. See, my days are cold without you. My days, yeah. And my heart can't take no more. I keep on. Okay, you guys, so I just left Barnes & Noble, and y'all, today was a success. I did get my CCRN Barron's book, so I'm really excited about that, y'all. I see everybody on my unit studying for their CCRN, and they always have the Barron's book, so that's what I'm going to use to study. And also, my unit or my hospital, they do like reimburse you. They give you a bonus if you do get your CCRN, and my manager, she highly encourages it, and I feel like it just makes you a better nurse. Like, you want to come to work and feel very proficient in the specialty that you work in. Like, you don't want to come to work and not feel like you are certified. Like, you need some type of more credentials to kind of show that you know what you're talking about, you know what you're doing with your patient, and it's going to help you advocate for your patient, help you know what's going on. So I'm going to get to studying. Like, even though you do have to have a certain amount of hours, typically you have to be working in the ICU for about like 1 to 2 years in order to qualify to take the CCRN. But I don't think it hurts to start studying early, because you still want to understand what's going on with your patient. So I'm really excited about that. Once I get through my major like residency classes, I'll go ahead and start studying for this, and I'll let y'all know how it goes. But I've been studying for about 4 hours at Barnes & Noble. I went over all of the medications that's going to be on my medication exam, and I feel pretty confident. Like, how I've been studying, I've been color coding. I actually rewrote out all of the meds. They gave us like a study guide, so I took the study guide, rewrote out all the meds, and then I just like to use like active recall. So I'll like talk to myself, teach it out. Like, as soon as I go over the medication, of course you want to know the class of drugs, the mechanism of action, the duration, like onset of the drug, also titrations, the max dose and the minimum dose, and then special like considerations for the medications, like what do you need to be monitoring for as a nurse, and then some contraindications, like what is the contraindication to giving this medication. So just like pharmacology, I just kind of go over it over and over and over again until I totally get it. And it does kind of makes sense when you've given these meds before. Now you understand like the exact mechanism of action, how it's affecting my patient. So it's one of those things where it's like some of it is from work where you just see the meds and you just start knowing it, and some of the meds that we don't give, you have to study those a little bit more. So I feel like I'm pretty confident. I do work tomorrow, so I don't know if I'm gonna have enough time to like go over it again, but I'm gonna try to go over at least like the vasopressors. I feel like those are the hardest because you know what they do, like you know that they're bringing your patient's blood pressure up, but you need to understand like what are the specific vasopressors, like if your patient has pulmonary hypertension, or if your patient is having a tachyarrhythmia but they're hypotensive, what is the best pressor to put them on. It's a lot of special things that you need to consider. Some patients can't get certain pressors, and even though like for our septic shock patients there's typically an order of pressors that we'll give, but some patients can't get that. So it's very important for you to know which pressors you can give and what, and the titrations and all that. So I'm hoping I pass this exam, y'all. I really don't want to have to retake this again, but okay, yeah. So now that I'm out, I'm actually gonna head over to the mall because I'm starving. Number one, I need to get some food, and I need to do some shopping because I booked my first trip as a nurse. So y'all, I'm not going nowhere out of the country or anything. I'll tell y'all in the next vlog where I'm going, but I just needed a trip to just clear my head, just somewhere nice, so I can just vibe out for a couple days. It's really hard to get like a lot of consecutive days off when you're on orientation because you have to work someone else's schedule. So I haven't been able to like book any trips, but for Memorial Day I have like 4 or 5 days off. So that's like my first stretch off that I've had with no classes, no work. So I decided to book a little trip, and I need to get some clothes, and since it was kind of the spare of the moment trip, I didn't have time to order anything online. So I'm gonna go try to find some cute little outfits, and I also want to get my toes done. So I may stop at the nail salon. There's a nail salon in the mall, so we'll see. But I know I gotta work these next couple days, so I just want to knock out all my little errands, go get some clothes, go have a little shopping day. So I'm excited. I will show you guys if I find anything nice at the mall, but I'll talk to y'all a little bit later. Hey y'all, so I'm out of the mall, y'all. Well, I spent like over 3 hours in the mall and only left for 2 outfits because I'm so picky, and I was trying on everything, y'all. Like I was really trying to buy something. That's the crazy part. Like I was in every single store trying to buy something and could not find anything that was like fitting my style. And I'm having a really hard time shopping for vacation clothes because I noticed that my taste in clothes is changing. Like I don't know if it's just because I'm getting older or finally maturing, but I don't want the same clothes that I used to like for vacation. Like I used to be like trying to get the spring break outfits and all the ratchet clothes. Like I'm just gonna keep it real, I was into the ratchet clothes, but now I'm in my like classy era. Like I want to look clean, I want to look classy, I want to look nice, I want to look like I put my outfit together nicely, especially when you're on vacation. Like you want to take pictures, and I want my pictures to come out nice, and I want to feel pretty. So I'm looking for all these clothes, and I'm not finding anything that's fitting my taste. So I was getting so frustrated, y'all. I was 2 seconds from walking out the mall with nothing, like nothing. And then I finally found something that looked nice. So I got 2 outfits, and I think I might go back to that store because it was getting late and I was in there for so long. So I tried it on, I really liked it. I found 2 cute outfits, and I probably will go back to see if they have anything else because the whole store was giving like my taste. So really like the 2 outfits that I got. Yeah, I didn't even have time to go get my nails done because I was in there for so long and I had to go do something else after I left the mall. So I didn't even have time to get my nails done, but I kind of wanted to wait till a little bit closer to my trip to get my nails done. I didn't want them to be all grown out, so I'll probably get my nails done next week. I have a lash appointment on Saturday, so I probably will get my nails done somewhere around that time so I can just do everything all at once. But I'm excited, got at least something that I like, because I was going to be so mad if I left that mall with no clothes. So I gotta go head home because y'all know I gotta work tomorrow. I got a 12-hour shift, so I will talk to y'all later. Bye. Good morning, you guys. Today is May 14th. It is Tuesday. I'm dressed and ready for work, y'all. This is my last 2 shifts on day shift, and I am so excited, y'all. Y'all know I'm not a morning person. I just can't believe I survived day shift for 11 weeks. That is insane. So I am so excited. I'm gonna go ahead to work. I'm praying for a good shift. Y'all know since I am on week 11, I am doing pretty much the majority of work of both my patients. So I'm praying for a really, really good shift. My last shift, y'all, I don't know if I ever told y'all, but I had one patient the whole shift and it was going great. Like I had a sweet, sweet lady. And when you have one patient, like you're able to do like everything because you just have one patient. So I literally was like, I gave her a bath early in the morning. I changed all her central line dressings, changed her A line, changed her PIC line, changed everything. I was like, dang, I'm like nurse of the year. Everything was going good. My patient had pulmonary hypertension, so I was starting her on a prostacyclin. And if y'all know, that's a very high risk medication. I've talked about it multiple times, but if it has a very, very short half-life. So if it's stopped for any reason, it can cause like rebound pulmonary hypertension and it can lead to death. So it's very serious. So I was starting my patient on that. And for some reason, the patient just was not tolerating it well. But I had the patient all the way till 5 p.m. And then I got a very, very sick patient from the ER. And y'all, I was preparing to get the patient, got the report, and pretty much the patient was in hemorrhagic shock when they came up to us. So that was like my first patient from the ER that was like actively crashing, y'all. I was starting them on multiple pressors. The patient was on 3 pressors. We had to do a central line dressing, a central line insertion and a A-line insertion all at the same time. The patient had like no access. The patient had IO. And it was just a lot going on, y'all. I was so overstimulated, but that was the first time that I was stabilizing a patient fully like by myself. My preceptor was actually in the other patient's room because my other patient was not tolerating the prostacyclin well. So it was a lot going on, y'all. And I did not leave work until 9 p.m. that day. So it was a lot, but I was asking for a critical patient. Like I actually went to the charge nurse and asked them if we can get an admission. So I was like, I can't be mad because I got what I wanted. I really wanted a really critical patient because I've never, I've had a couple admissions from the ER, but my admissions have been really chill. So they've just been like coming for monitoring or just kind of just watching them. They haven't been like an actively declining patient. So I really wanted one of those cases and I got it, y'all. So it was really good. But I actually was able to come by like a couple days later and check on the patient that was in hemorrhagic shock. And the patient was actually doing much better, extubated. I had to rush the patient to surgery, so the surgery went well. So I was like, I'm just glad to see that the patient had a great outcome, even though I had to be there so long. I was happy to see my patient was okay. So we are praying for a good shift, a critical patient, but a good shift. So I am going to update you guys at the end of this shift, let y'all know how it goes, and I'll talk to y'all later. Good morning, you guys. Happy Wednesday. It is May 15th, and on Wednesdays we wear pink. So I did not come back to y'all last night, y'all, because when I got off of work, I was extremely exhausted, y'all. Like the day that I had yesterday really, really challenged me. Like I was just running around all day. I had some very sick patients. My first patient was in septic shock and multi-organ failure. She was on multiple pressors, intubated on CRT. And then my other patient was also intubated, very sick, and just had a major upper airway surgery and also had cancer. So it was just such a hard shift, and I really felt like that wasn't a good assignment because both of those patients was very critical and they needed some individual attention. And it was so hard because I was transporting my patient to CT, constantly coming back and forth. And then I feel like what makes nursing so hard that people don't talk about, but as a nurse in the hospital, you are literally doing everyone's job. Like, you can't just come to work and be a nurse. You are pretty much acting like the doctor, the pharmacist, the transporter, the dietitian, PT, OT, the therapist, the social worker. Like, you are everyone in the hospital. So when things don't get done, it's like everything falls back on you. So, like, for example, if a patient has a surgery plan, and this actually happened to me before, but I had a OR nurse that called me and was like, oh, has the patient got consent yet for the surgery? And I'm like, no, a doctor has not came up here to consent the patient. And she was like, well, you need to get consent for the patient for the surgery. I'm like, I'm a nurse. I don't consent patients for surgery. If you know, then you know that us as nurses, we can witness a consent, but the doctor or the surgeon, whoever is performing the procedure, is the one that needs to consent the patient, not the nurse. So it's just like when you're a new grad and you don't know the way things are supposed to operate, people will try to get you to do anything, and like, you really have to put your foot down and be like, that is not my responsibility, and I'm not gonna take the fall for you guys not coming to get consent for a patient. So it's just certain things that are just unacceptable. Like, I feel like nurses should not be put through this much work and nobody is like helping us. And to think that we spent a whole 12 hours doing everyone else's job, and then right at 7 o'clock everyone's running out the door going home, but we're the ones that got to stay till 9 p.m. to chart because we had to go do everyone else's job. Because I really feel like if nurses were not in the hospital, things would just not be getting done. Like it's some days where I'll be coordinating with people to come do a procedure on my patient, or to come to take the patient down to go do something, and just no one shows up, and you have to constantly keep calling and following up in order for anything to get done. And it's just not fair. It's really not fair. So I think that's what it really was frustrating me with yesterday, is because every time I was trying to do something was coming up. Like, try to take a patient down for a CT, but then the CT person is not available, or I can't get in contact with CT, can't get in contact with the family, can't get in contact with the pharmacist, can't find a medication when the pharmacy said that they were going to tube it up. Like, I was sending labs down for my patient to get blood work. I'm checking the labs are not being processed. I gotta call lab, figure out why my labs are not being processed, trying to figure out why IV team can't come, trying to figure out all this stuff. And I'm just like, why can't nothing just go smooth? Like, it's just really difficult, y'all. It's really difficult. But off of that topic, I am on the way to work. Y'all know I have a medication exam today, and y'all, traffic is so bad right now, and I'm really praying that I'm not going to be late because traffic is insane. So I'm praying I'm going to get to work on time. So I will update you guys. This test is like a 50 question like medication test. So I have been studying. I'm gonna leave it up to God. We do have 3 tries on this exam, so our educators were like, don't be too stressed if you don't pass the first time, like, just retake it. It's not like nursing school, y'all. So I still want to get a good grade. I want to pass the first time because these are medications that I'm going to be using, titrating by myself off of orientation, and I don't want to be messing up on nobody's medications, y'all. Like, no. So praying everything goes right, and I will talk to you guys probably after, because it's gonna be a really long day, y'all. It is 7 o'clock. I gotta be there at 8, and it's gonna be from 8 o'clock to like 6:30 p.m. So I'll come back to y'all at the end of the day and let y'all know how it goes. Hey y'all, so I am out of my medication test and I'm out of my class for today. And y'all, today was a lot. Like, I gotta go over the whole day because it was a long day, but I got out early. It's only 4 o'clock and I thought I was gonna be there till 6. So a win is a win. But when I came in this morning, I told y'all I have to do my medication test. It was 50 questions, y'all, and your girl passed. I got a 96, so I think I only got 2 or 3 wrong. But that test was kind of hard, I'm not gonna lie. Like, some of the questions were very simple. Like, some of them was just like, what is the titrations for epinephrine, or what is the class of this medication? And some of them were like, if a patient comes back from surgery and their blood pressure is 200 over so-and-so, what titrations would you do for cardine? And like, just kind of giving you like situational questions, so you really had to kind of think about it. And then it was questions about like CY patients, Ativan, Precedex, dobutamine, dopamine, levo, just all the pressors that we titrate and all the blood pressure medicines that we give in the ICU. And a lot of those drugs have some bad side effects, and it can be really bad if you don't know how to titrate or watch out for like signs and symptoms of those medications. So I'm glad I passed that exam, so I do not have to retake that. But we also went over all of the rapid response things besides cold blue. We talked about cold blue as well, but we went over some other like medical emergencies like seizures, cold stroke, cold STEMI, and then of course cold blue. And if your patient's having some type of arrhythmia that is lethal, or something that is not providing perfusion to their body. So I'm so glad that I did that ALS class last week, because that really prepared me for this class, because I did not know that our educators was also going to be doing a simulation. Even though I just did one in that other class, we did another simulation. So I am really, really glad that I went to that class, because it prepared me for what was going to be happening in my real simulation with my educators. And they said we did amazing, y'all. Like, it was a hard simulation, but they were like watching us, and they said that we checked all the boxes. Like, I came out of the simulation and they didn't have any like constructive criticism or anything, so I felt like we did pretty good. And I was the team leader. I was the leader of the code, y'all. People always be nominating me. They be like, I'm finna have Destiny be the leader, and I'm like, y'all. But look, I love running things. Like, that is probably why I like ICU, because I like to feel like I am controlling the situation. Like, I don't like when I'm in a situation and I cannot be the leader, or if I don't know how to problem solve, get things done. I like to be the person that saves the day type thing. So being an ICU, like, you feel like you the boss. Sometimes you be having to boss the providers around. Like, sometimes you have to educate the doctors on what's going on, because you are the nurse and you are with the patient longer than the doctors are. So I liked how I was just able to run the code, run the simulation, be able to interpret the rhythm, and just know what's going on. It's like it finally starting to make sense, and doing it over and over again, it'll finally start to click. So hopefully when I'm with the patient in that situation, I know exactly what to do. So the class was really, really good, and I thought I was going to have to stay till 5 p.m. because I had a second class that was going to go over how to set up flow track. But since we got out of our simulation early, the flow track person that was doing our class was having a session at 2 o'clock. And thank God, because then I would have had to stay till 5 p.m. if I didn't go to that 2 o'clock class. But y'all, the flow track lady actually really helped explain a lot of things too, because for y'all that don't know, in ICU we do a lot of hemodynamic monitoring. But the thing with hemodynamic monitoring is that if you don't understand exactly what you're looking for, it's very hard to understand what's going on. So, for example, if you have a patient that has a Swan-Ganz catheter or a CVP monitor, and it's telling you numbers, but as ICU nurse, we have to be able to interpret what does that number mean, because she was pretty much explaining that most of our teachings in nursing school is basic vital signs, so blood pressure, heart rate, the respirations, O2 sat, and all that. And those are very important numbers, very important values. But when we are assessing for a patient that is hemodynamically unstable, we have to first understand, what does that mean? So, for example, when a patient is in the ER and the ER is calling us and they're like, the patient's blood pressure is 60/40. The reason why us as ICU nurses are immediately like freaking out is because that is not enough perfusion to perfuse your vital organs. And your vital organs are your kidneys, your heart, your brain. Those are main things, like your GI tract, all of that. Even though it may not be the most vital, it's not enough blood flow to those organs. So if a patient's blood pressure is that low, they are hemodynamically unstable. But the thing that is very hard to figure out is what is causing this. So for our septic patients, we know that what's causing the patient's blood pressure to be very low is because sepsis causes your whole body to vasodilate, and it decreases your systemic vascular resistance. So that's why we have to put patients on pressors like levo to increase that, so that we are also giving them fluids and giving them pressors to help to increase the resistance in order to get their blood pressure up. But patients that are in hypovolemic shock, their blood pressure is low because they are bleeding out and they need volume, they need fluids. So it's always, sometimes it's obvious what's happening. Obviously, if the patient comes in and they're bleeding out, then you know why their pressure is low. But there's sometimes where patients come in and you may not know what's the immediate issue. Or sometimes we can overcorrect the problem. So a patient could be dehydrated, but then we give them too much fluid and now they're in some type of fluid overload now. So it's really hard to understand, like, what is my patient's problem and how can I assess for this? So in nursing school, of course, they're going to teach you the signs and symptoms of all of these, like of shock, of dehydration, of all of this. But then when you're looking at it from a patient point of view, sometimes all the signs and symptoms look the same. Like a patient that's dehydrated can also look like a patient that is in shock. Blood pressure low, heart rate high, dry mucous membranes, they're not peeing, the urine output is low, like, but what is it? What is causing it? So that's what the flow track is actually supposed to help us be able to figure out, is it gives us some more information, like the patient's stroke volume, cardiac output, SVR, and those values can help us be able to diagnose what is the patient's problem, and we can figure out, are we giving them too much fluids, are we not giving them enough fluids, like what is going on, so that we can properly treat the patient. So that class really helped tie things together, y'all. Like, I'm so glad that I leave these classes with some type of knowledge to be able to apply to my patients, because I don't like being in a situation and not know what I can do to like help my patient, or at least advocate, because sometimes the doctors may not know, but if you know, then ask the doctor, hey, they're on pressors, but I'm thinking that it may not be a blood pressure thing, it may be the heart is not pumping enough, and the patient may not need to be on pressors. The patient could need to be on a inotropic type of medication to help the heart contract in order to increase the blood pressure. So it's a lot of things that we can do as ICU nurses that can really help our patients out, y'all. So that was a good class. I know that was a lot, but I like to tell y'all things that I learned so that y'all can, like, you know, apply this. I know in nursing school, they don't go this in depth, and when you become a nurse, you start to realize how important this is, because you are seeing all these signs and symptoms before things even become a problem. So if you know what to look for, then you can really advocate for your patient and save a life, like, for real, y'all. So today was a good day. I'm off tomorrow, so I'm probably gonna go to the gym, just do some self-care, and then I have my last day shift on Friday, so I'm definitely gonna vlog that for you guys. But I will talk to you guys later. Bye. Hey you guys, today is May 16th and I am off today. It is Thursday, so today I gotta run some errands. I told you guys tomorrow's my last shift on day shift, and I want to get my preceptor something nice, so I'm gonna stop, get her a gift card, give her some type of like candy or something, and put a nice little card in there so I can give it to her tomorrow. And then I also got to stop by Walmart, get some stuff for work tomorrow, and just do some little errands. And then I got to come back, and then I'm going to go to the gym a little bit later, y'all, because, y'all, I fell off the gym because residency was getting so busy, and I just fell off. So I'm gonna try to get it back going. I know being on night shift, like, you can pack on weight very, very fast on night shift because all the snacking, it's a lot of downtime. So I need to make sure that I'm getting in that gym. But I will talk to y'all on the way to Walmart, and I'll let y'all know when I get my Preceptor. Bye. See, my days are cold without you, but I'm hurting while I'm near you. And though my heart can't take no more, I keep on going back to you. Without you, but I'm hurting while I'm with you. And though my heart can't take no more, I keep on going back to you. Baby, I don't know why you're treating me so bad. You said you love me, don't wanna bump me, and I was all you had. Good morning, you guys. Today is May 17th, and it is my last shift on day shift, so I'm so excited. Yeah, I didn't even come back to y'all yesterday. I had a busy day yesterday, so I did get my Preceptor a gift. Let me show y'all. I got her this little gift. I got her card, a gift card, some candy, chocolate, all the stuff that nurses like. So I hope she likes that. And after that, I did go to the gym, and then I also went out to eat with my family. So I had a pretty good day yesterday. I'm just celebrating getting through day shift because y'all know it is hard. If y'all ever work in an ICU on day shift, you'll see how busy it is. So I got through it. I'm so excited to start my new night shift journey. And I literally only have one day off before I have to go to night shift. So super excited about that. But today, I'm just hoping that I get through this shift. I'm hoping today goes great. I'm praying that I have a great patient, great day. And I think I may try to get to work a little bit early because I just noticed in the morning, sometimes I get so overwhelmed because I feel like I haven't had enough time to like go through my patient's chart, figure out what's going on. And then you instantly, like right when you come in day shift, you instantly got to get to work. You don't have time to be running through a whole bunch of stuff. So I feel like if I get to work a little bit earlier, I'll have a little bit more time to go through the chart, and then I'll feel a little bit more prepared when I'm in round. So that's what I'm going to do today, and I'll see how that goes. If that goes well, I may do that on night shift, but on night shift, you typically are not like coming into something super, super crazy unless it's just an emergency going on. But I'd rather be prepared than not be prepared. So I will let y'all know how my last day shift goes, and I'll come back at the end of the shift. And today will actually be the end of the vlog. So after today, I'll go ahead and end this vlog and upload this video for you guys. So talk to y'all later. Bye. Hey, you guys. I am leaving my last day shift ever, y'all. Like, to think that I, as a person that has been on night shift for 2 years, survived 11 weeks of day shift, that is a big thing for me, y'all. Like, I am not a day shift person. Like, my personality is just does not give day shift. And I love interacting with my patients and their families. It's just a lot that goes on in day shift. That's just a lot for me. Like, I get overstimulated, not that fast, but I do get overstimulated pretty quickly. So when there's like all the testing, all the procedures, all the rounding, all the doctors, it becomes very overwhelming, y'all. So to think that somebody like me survived day shift is crazy, y'all. I am so excited to be going back to my crew, my home. And then, y'all, the fact that like everyone on my unit is like so excited and they're so ready for me to come back to night shift, I'm just so excited, y'all. I just know that I have a team that I can trust, that is supportive. I know that I can really go to anyone on night shift and feel comfortable. And that's why I'm not terrified about being alone or being off of orientation, because I know that I'll never be alone. Like nursing is already a team effort, but when you trust the people that you work with, you are even more like you feel even more supported, that you know if something goes down, like they have your back. So I'm just so excited, y'all. I am on the way home. I actually got out pretty good, and today was a great shift, y'all. I actually had a patient that I had earlier this week on Tuesday. I I had that same patient back, and the patient is doing much better. I was able to take them off of CRRT, which is the continuous dialysis. So we discontinued that. The patient is like up, alert, following commands. They're still intubated, but they are doing much better. And then I had another patient that came after abdominal surgery, and she was so sweet, y'all. And like, when you are on orientation and you have like your preceptor coming in with you, sometimes patients could be a little like feel some type of way because they know that you're a new nurse, and sometimes people don't feel comfortable with like a new nurse, like, you know, taking care of them. Like, they would rather have the experienced nurse. But I told them, like, I'm on orientation, and at first, like, I could tell in the beginning of the shift, she was a little hesitant. She was like, is this your first day? And I was like, no, like, girl, this is my 11th week, like, please. I was like, can you give me a break? But she actually grew on me, and she was like, you're actually a really good nurse. And she was like, to only be doing this for a couple weeks, like, you're doing amazing. And she was like, I could tell you really have this down. And she just told my preceptor that I'm amazing. And y'all, I was doing my morning assessment on her, right? And like, I had my stethoscope, I was listening to her bowel sounds, because obviously if she just came out of a surgery, I want to make sure, see if her bowel sounds came back. And I was assessing her site, and I was just checking her pulses, you know, doing my main complex assessment. And she was like, is there something wrong? And I was like, no, like, what's going on? And she was like, I've just never had somebody do like a thorough assessment on me. Like, I thought something was happening. And I was like, what? That's kind of sad, y'all, to think that like a lot of nurses do not be fully assessing their patient. And I mean, I know that when you get like more experience, like the more experienced nurses get, like, they don't typically do the full like coming in, just doing the full head to toe, because they kind of have seen everything. But me personally, like, I don't like skipping those steps, because there's minor things that you can miss when you don't do a thorough assessment on your patient. So the fact that she said, like, since she's been there, and she's been in the hospital for like 10 days, so the fact that she hasn't had anybody do a full head to toe assessment, and she told the doctor that like she wants us to stay on the unit just because she's like so satisfied with her care, that really made me feel good as a nurse. And it made me want to make sure that I am not like skipping any steps, not providing the best care for my patients, because I don't never want a patient thinking like I did not fully assess them, or I didn't take the time to really make sure that they are doing well. So just for y'all that are like new nurses that think that, you know, after you get out of school, like, you could just forget about all the things that they taught you in nursing school, like, no, make sure that you still are doing your thorough assessment, be detailed, take good care of your patients. And yeah, it just felt so good doing my last rounds, because y'all know in the morning we do rounds in front of the doctors, and like the fact that like I've come in so far, like in rounds I used to be all shy, now I'm like, I need an order for this, the patient's blood pressure is low, I need to put them on levo, can you order this? I'm very detailed now, and I don't have an issue like expressing my concerns to physicians anymore. And I kind of know like what to look for and what is normal, what's abnormal. So it just feels really good that you came so far from when you first started to seeing like towards the end of the journey, y'all. It's such a good feeling. So for y'all that is new grads that are in like ICU, or even if you're just on a regular unit that's like taking you a while to kind of get comfortable, like, it does come with time. Like, I still like have my days where I'm just like, this is a lot, like I'm getting overwhelmed, but then I just learned how to just stay cool, stay calm, and get through it, y'all. So I'm so excited. I know on night shift I'm gonna have much more time to really be detailed, take time to assess my patient, and really figure out, get down to the bottom of like what's going on. So that's what I'm most excited about with night shift. It gives you more time to really be assessing your patient. So I'm so excited. I'm gonna go ahead and end this vlog out, because the next vlog is gonna be my first week on night shift as a nurse. So I'll go ahead and start that new vlog for you guys. But please like, comment, subscribe if you like my videos. If you want to see more nursing content, I got more videos for y'all coming soon. But I'll talk to y'all later.